Good evening. I'm Beth Anderson, and I am the Executive Director here at Hill Learning Center, and I want to welcome you to this, our final event in our Community Education Series for 2018-19. Thank you so much for coming out. I know what a busy time of year it is and how many places you could be, so we are really grateful that you're choosing to spend this time with us here this evening. Can I just see by a show of hands, for how many of you is the first time you're attending a community ed event here at Hill? Wow, fantastic. Well, a special welcome to all of you. And of those who it's their first time at Community Ed, is it your first time at Hill? Raise your hand if it's your first time at Hill altogether. Well, thank you so much. We are thrilled to have you. Hill Learning Center, we've been here for over 41 years. We have a lot of programs. We have programs for students, a half-day school for students with diagnosed learning differences and attention challenges, and also summer programs and tutoring programs, and also do a lot of outreach work and teacher training and partnership with public schools, private schools, charter schools around the state of North Carolina and really throughout the Southeast. You can see on the back wall there some of the school districts that we're working with across the state to support their teachers in helping their students with learning differences. The Community Education Series is something we started a few years ago as an effort to really also give back to the community here. It is a free resource. We thank our sponsors, Morris Commercial and the Morris family, for making this available. And throughout the year, we like to bring in different experts and topics. Sometimes we'll do films, topics that we think are of interest to parents and educators who are all working to support the 1 in 5 students who have learning differences and attention challenges. So that's a little bit about who we are. We're really grateful that you are here. I'll be around and some of our staff will be around later if you have any questions or want to learn more about Hill Learning Center. And if you happen to be around on April 28th, we have a great event here called the Hill Mile, which is also raising money for student financial aid, so we'd love to see you there. But without further ado, I want to turn it over to our friends, Dr. Naomi Davis and Julia Schecter, from the Duke ADHD Clinic. We are incredibly lucky to have this clinic and this resource and these experts right down the street. They've come in and delivered professional development and training for our faculty before. We've talked about research. They offer, the Duke ADHD Clinic, they may tell you more about it, but offers a range of comprehensive services for families, for children, for adults. It's really just a phenomenal thing to have here. And we are thrilled to have them here with us this evening to share some of their expertise. So thank you.
All right, so it's really wonderful to be here. I just want to make sure that we have sound working. Okay, so I'm doubly mic'd, and I may need a couple prompts to keep all the mics in the right spot, but hopefully you can hear me and just signal if you can't. So I'm Naomi Davis. This is Julia Schecter, and we're really excited to be here talking with you tonight about ADHD. We are both clinical psychologists in the ADHD program at Duke, so just down the road. And as part of our role there, we work as clinicians and as researchers, and we're also involved with training. So we have clinical psychology interns and graduate students who work with us. We have a faculty of about 8 psychologists, and we work closely with other providers at Duke and provide a range of services, as was mentioned, including evaluations and treatment. And so we've got a lot of information that we're excited to share with you tonight. We're going to kind of run the gamut, actually, talking a little bit about ADHD more broadly, and then moving into treatment as we go along through the evening. I think given the time and the fact that we've got a lot that we want to share and we're both excited to share with you, we're probably going to save questions until the end. So make a quick note if you have something that pops in your mind that you want to be able to ask us toward the end of the presentation. And anything else, just by way of introduction? Okay. So this is just a little bit of an orientation to what we're going to talk about today. We're going to start out with some basic overview about what is ADHD. We'll give you some of the big picture information that you may or may not be familiar with, but we find that's a really helpful place to start a presentation like this, just to get everybody on the same page. Then we will move into some details about prevalence and clinical presentation of what ADHD looks like, including across the lifespan. We'll spend just a couple minutes talking about the diagnostic process for ADHD, and at that point I will hand the mic over to Julia, and she's going to pop in and spend the rest of our time really focusing on evidence-based treatments for ADHD. So that is the plan for the evening. Anything else?
Maybe just, hello. Maybe just getting a little bit of a lay of the land. I think the batteries might have gone again, yeah. But I think you can hear me at least here because I have a really loud voice. So just to kind of get a lay of the land of who's in the audience today, just if you don't mind raising your hand if you're a provider or in the school system, perhaps. What about parents? We thought that might be the case. What about just to kind of get a sense of age ranges, parents for kind of preschool, kindergarten age, a couple, school age, elementary school age, the majority, middle school, okay, high school. Anyone we've forgotten later and, okay, excellent. That gives us a good sense. Thanks.
Excellent. Okay, so I'm going to just dive in with a quick definition here. So as most of you know, ADHD stands for Attention Deficit Hyperactivity Disorder. We understand that ADHD is a brain-based disorder, and it causes difficulties in three main areas. These are inattention, hyperactivity, and impulsivity. And when we're talking about disorders, we'll go through some more details when I get to the diagnostic section, but we're really talking about levels of inattention or levels of hyperactivity or levels of impulsivity that exceed expectations for a person's developmental level. And obviously, as you can think about, what that means for a preschooler is different than what it means for a school-age child or a high schooler and beyond. And a lot of people wonder, and ADHD does come up a lot in the press. It comes up in the news, comes up probably in conversations you might have at cocktail parties and things like that, where people wonder about ADHD and what's all the hype about ADHD recently. One of the things we like to think about with families is that ADHD has actually been around for a long time. There's definitely a lot more attention to ADHD right now. There's a lot of focus on treatments and medicines and things like that, which we'll get to a little bit later. But we do know from a few great researchers who have dived into the literature that there are references to ADHD going way back into the late 1700s. And so the phenomenon that we now have a name for, and we now have treatments for, and we have ways to address and strategies and ideas like the things we want to share with you guys today, this phenomenon has been around for quite a while. And in terms of the diagnostic labeling system, most people are more familiar with the labels that we've given to ADHD in the more recent decades. And some of you may know, if you've gone through the diagnostic process before, that we have a guideline, a tool that we use when we're looking at psychiatric disorders, and we try to understand them. And the guideline is called the DSM, or the Diagnostic and Statistical Manual. So the version of the DSM that we're in right now is up in the top right corner here. That's the purple book. And this volume came out in 2013, but you can see that over the years, the phenomenon of ADHD has been described and categorized across the decades in these different volumes and contribute to our current understanding. And as there's more research on the subject, and that informs the next evolution of the diagnostic criteria and help us really understand what is ADHD and what do we understand about it and how can we treat it. So let me just pause and go through the diagnostic criteria. And again, as I mentioned, a lot of times the term ADHD is thrown around fairly often. I find it very helpful for families to really stop and orient themselves to what the criteria are for ADHD. Like I was saying a minute ago, ADHD is defined by levels of inattention and hyperactivity and impulsivity. All of those are things that we all experience to some extent sometimes. And when we're talking about ADHD as a disorder, we're really looking at levels of those behaviors that meet these specific criteria. And that's what contributes to making something a clinical disorder. So as we're thinking about the current criteria for ADHD, these are the things that we look for. So we're talking about having a certain number of symptoms that are excessive for a person's developmental level. And the number of symptoms required is 6 for children, and actually 5 for adults. That starts at age 17. But having symptoms is only just a piece of the disorder. So in addition to symptoms, we look at things like when do the symptoms start. And they have to start before age 12 as part of the diagnostic criteria. They have to be present in more than one setting. So these symptoms aren't things that are just true in one moment in time or in one place or another place. They really have to be true for the person across different settings. And that's part of that brain-based feature of ADHD. What we understand from a lot of the research right now is that ADHD has, I'll show you in a few minutes, but some differences in the brain development. And that means that if it's part of my brain, it's going to be true for me in the different settings that I operate in. We also have to look for evidence of impairment. So having symptoms isn't just enough, but the symptoms that are present have to cause a problem. And we have to rule out other possible explanations for those symptoms. And so what all that, what all of that adds up to, what all of that adds up to is that, am I no longer, I'm good? Okay. What all of that adds up to is that sometimes people have ADHD with more symptoms of inattention, and that's at the bottom here. We call that predominantly inattentive presentation, and that's what in the old days some of us called ADD, or attention deficit disorder. So now we call that ADHD, predominantly inattentive presentation. Less commonly, we have individuals who have more hyperactive and impulsive symptoms and fewer inattentive symptoms, and we call that ADHD, predominantly inattentive presentation. And then most commonly, we have individuals who have both, and we call that ADHD combined presentation. This is way too much for you to take in right now, but I like to show this slide because I want everybody to remember that when we're thinking about ADHD, we're actually talking about 18 different symptoms. So people have to have 6 out of 9 symptoms of inattention, or 6 out of 9 symptoms of hyperactivity and impulsivity. Those are up here on the right. But because you have to have 6 out of 9 or 6 out of 9, the way ADHD manifests or looks for one child or one individual isn't going to be exactly the same as it looks for another person. The way your symptoms present might differ, but they're going to have a certain kind of impact on your functioning that we'll talk about. But these are the symptoms, and these you can find online for sure if you're looking them up. One thing that you might notice if you've looked into ADHD before, or if you were a super fast reader and you could read all those symptoms that I just listed, is that there isn't a lot about emotion regulation or what we call self-regulation in general in the symptom list for ADHD. But if any of you is a parent of a child with ADHD, you might have experienced that emotion regulation or trouble regulating emotions is often a piece of the puzzle. And so that falls into this category of self-regulation more generally. And there's some really interesting work that's coming out now that you might find, you want to follow up on, look at. And we actually included the name of one reference that's really parent-friendly and interesting to peek at, which can help us think a little bit more about what are these aspects of self-regulation that are lagging in individuals who have ADHD. What does the science tell us about it, and more importantly, what can we do about it? But the way we think about self-regulation is that it has to do with our ability or our capacity to optimize our behavior and our thinking and our attentional capacity and our emotional experience and how we express those emotions. And when people have ADHD, often this is an area that's really challenging for them. How do I call upon all of my faculties to optimize my behavior in a given situation, regardless of what's going on around me, or to optimize the way I express and act on my emotions? And all that falls under this category of self-regulation. And the reason self-regulation is so important is that we need those skills to be able to check out what's going on in our environment, filter that information through the different lenses that we have, and then act accordingly. So as I'm talking to you, I'm trying to take in everything that's going on. I'm trying to hold my microphone the way I'm supposed to. I got my clicker in my hand. I'm looking to see if you guys can hear me in the back. And I'm trying to regulate my speaking accordingly. And that capacity of self-regulation is an area that you won't find it on a DSM checklist for ADHD, but it really is, in essence, a lot of what the difficulties are that your children might be experiencing. There is a link at the bottom here that I'll point out, and I think Julia probably has this on a later slide as well. And this is to an organization called CHADD. Has anybody checked out CHADD before? CHADD, so 2 Ds, .org. And so I put the link here for a little article they have about executive function and self-regulation, but there are many, many articles on that website. There's information about treatment, information about diagnosis, recommendations about schools and whatnot. And so it's definitely worth checking out. You have probably, if you're like most people, Googled and stumbled on lots of information. One of the things we hope to highlight tonight are recommended information, things that we think are valuable and really scientifically based resources, and the CHAD website is definitely one of those. So as part of this overview of ADHD, there are a couple of other things that I definitely want to highlight tonight. One of them is that as we've learned more about ADHD, and we've learned much since that first paper that I showed you briefly from the late 1700s, we do understand that ADHD is a genetic disorder. It is a highly heritable disorder, which means that much of the variance or much of the likelihood that an individual has ADHD is going to be accounted for by their genes. Some of it will be accounted for by other things in the environment, but there is a huge genetic component to ADHD. So clinically what we find is that Julie and I do a lot of evaluations with children and with adults. Many times when we're working with children, we find that a parent either has ADHD or feels like, wow, this sounds really familiar. This feels like something that I experience too. So the data suggests that it's going to be maybe 25 to 50% of the time that a parent will have ADHD when their child also has ADHD. So ADHD runs in families, and we know that it's genetic. It's not so simple. There's no one gene. So there's lots of folks who are out there trying to understand the genetics of it, and genetics is not something that I specialize in, but what I can tell you is that there's no one gene. There are probably multiple genes coming together. And in fact, probably multiple genes coming together to put somebody at risk for ADHD, probably in conjunction with other factors. So this is a complex thing that a lot of scientists are working on trying to understand. When we think about the environmental factors, there have been a lot of studies that have tried to understand what is it exactly that puts somebody at risk besides their genes, or maybe in addition to their genes, to have ADHD. And so you can see a few of these factors at the top. These are things that have been looked at, and I absolutely want to highlight none of these things at the top of this slide here are causal. So when we think about prenatal factors, maybe an illness or an injury in utero, or when we think about birth factors, anything that's traumatic events that can happen during the birth process, or exposure to environmental toxins like lead, dietary factors in terms of nutrition, psychosocial adversity. There have been studies that have shown these are correlated with having ADHD or associated with having ADHD, but none of these are causal or causing ADHD. And I know that many times families are looking for understanding, looking to try to understand how is it that this child has this collection of difficulties. And we don't really have answers for why, and we can't really do a blood test or point to any particular reason, but we can look at patterns and try to understand as a whole what are the things that might predispose somebody to having ADHD. So just as I'm not a geneticist, I am also not a neurobiologist, but I do think that it's helpful for us to orient ourselves and for the public to really understand that there's a lot of really solid research going on to try to understand what is happening in the brain that helps us understand ADHD. And so what we do know is that when we have studies of thousands and thousands of people where they compare the brains of individuals who have been diagnosed clinically with ADHD and individuals without ADHD, there are certain structural differences in the brains that suggest or are indicative of ADHD. There's also evidence that those structural differences in the brains are correlated or associated with things like behavior ratings of ADHD symptoms. So we're collectively, the scientific community is gathering a lot of information to help us understand the brain-based nature of ADHD. What I think is really important and is relevant, especially for those of you who have younger children, is that some of the findings suggest that there really is a delay in the development in certain parts of the brain in kids who have ADHD compared to their peers. And so this picture here with the pretty purple images showing you different parts of the brain shows that in the prefrontal region of the brain, that's the part of the brain that focuses on things like attention and planning, there's a delay of 2 to 3 years in the development in kids who have ADHD. So a lot of times when I'm working with families and we've got kids who are sort of mid-school age, and they say, wow, you know, he really seems to behave just like his 6-year-old sister. or seems to get along really well with the kids in the neighborhood who are a few years younger. And a lot of times we think maybe that really is that the delay in the brain maturation, where kids tend to be operating a few years behind their peers. We don't have a lot of longitudinal studies, meaning studies where we follow kids over time and do repeat brain scanning over time to really understand the pattern of brain development. But we are starting to put that picture together based on the research that has been done. So I'm going to hop in a little bit and tell you a little bit about the clinical presentation of ADHD across the lifespan. And we'll go through this part pretty quickly because we want to definitely get to the treatment elements. So these are my little guys here. So I think most of you know ADHD can happen in girls and guys, but I just happen to have this cute picture of guys growing up. ADHD does tend to persist across the lifespan. So I'll just, for a moment, walk you through what it looks like in preschoolers, more school-age kids, slightly older kids, and I think the last one, it maybe looks like a teenager, but it's supposed to be more of an adult. So in very little kids with ADHD, I didn't see any hands raised for preschoolers, but what we tend to find, in addition to those core symptoms, so remember that to get a diagnosis of ADHD, you have to have those core symptoms that I talked about a few minutes ago. But this is sort of what does it look like, or what does it feel like? And in particular, if you're a teacher, what does it feel like in your classroom? Or if you're a parent, what does it feel like when you're parenting? The young children with ADHD tend to have a real low level of compliance. It's very hard for them to stop what they're doing and do the thing you're asking them to do. They are even more on the go than their preschool peers. It's very normative for preschoolers to be on the go, but young children with ADHD are more so than their peers. They tend to do everything in sort of a big way. So they have tantrums just like all little kids do, but their tantrums are excessive, they're bigger, they last longer, they're more frequent, they're argumentative, and when they play, they tend to really play hard. As kids go into school age, we see fewer of those problems, and we see more things like class disruptions, difficulty doing homework, being easily distracted, unwilling to complete tasks. And when kids get older into adolescence, I know there's a few here who have high school and middle school and high school age kids. The expectations of the environment absolutely change for those kids, and their behaviors do change. So they're not necessarily running around the classroom at that age, but they describe having an inner feeling of restlessness and maybe asking for a bathroom pass to go to the bathroom more often than their peers just because they have this urge to get up and move around. They tend to be more disorganized with their schoolwork, and of course, accordingly, there's many more things we ask them to organize as they get older. They have trouble working independently, and they tend to engage in more risky behaviors. And kind of as you follow across the lifespan, these are just some aspects of what we see when we work with adults who have ADHD, so difficulty gauging time, difficulty finishing and starting projects, sometimes job difficulties or relationship difficulties. So as I mentioned, ADHD does tend to persist across the lifespan. We haven't talked yet about prevalence. When we ask kids this question, we'll ask kids often, how many kids do you think in your class have ADHD? And often they'll say, like, half the kids in my class have ADHD. And usually what we think of as the true prevalence of ADHD is about one child per class, so about 5%, 5 to 8%. That's what the good clinical estimates will show us. And that's been consistent over the years and actually is true even in other countries. If you do a little diving around on the internet, you will find a wide range of prevalence estimates. And a lot of that we understand to be associated with different ways of measuring and asking the question. But if you do really good clinical studies where you're doing the kind of diagnoses that we'll talk about in a few minutes, the estimates are about 5 to 8%. Over the lifespan, some people with ADHD do have reductions in their ADHD symptoms. And so here you can see the symptoms tend to drop in adolescence and then tend to drop again in adulthood. But we do find a lot of studies now converging to show about 2/3 of kids who have ADHD maintain that diagnosis into adulthood. And sometimes even if you don't have the full diagnosis in adulthood, you might have sub-threshold or a certain number of fewer symptoms than you would meet the criteria but still have impairment from those symptoms. So as a psychologist, part of my job, if I put on my diagnostic hat, is to sort of say yes or no, this person has ADHD. But a more important part of my job is to say, if you think these things are getting in the way for you, what are some things we could do about it? And so the rates are going to suggest a certain number of people are going to maintain their diagnosis, but either way, when individuals are struggling in the areas that we're talking about, there are strategies and ideas that we can offer to help. So in terms of the impact, right, so we've talked a little bit about what the symptoms are. We've talked about kind of how does it show up. There's just a couple more slides I want to highlight about how does ADHD impact children. So impacting in terms of the childhood period, but also into adulthood. That'll be the next slide that I show. And I think the great thing is we've got a lot of interventions to support kids with ADHD, and we also know that having ADHD presents a real challenge for kids, in particular in the classroom setting. So all the things that we ask kids to do at school are kind of the opposite of what their brains and bodies want to do at that time, right? Like if I'm a kid who needs to move, and I can do great when I'm in a setting where I can move, it's very, very hard to be in a classroom all day where I have to sit. Or if I'm somebody who's just always got a story to share and I'm really, really talkative, that is fabulous in certain contexts, and it's really, really hard to control that in the school setting, and it's not as valued in the school setting. So school is a difficult place for kids with ADHD, and here you can see just a list of some of the ways that it does affect kids. So what we find is even in the absence of learning disabilities, many children with ADHD have problems with their academic performance. It's just hard for them to produce enough work. The output is reduced compared to other kids. A lot of these kids end up in special education services. We do see higher rates of office referrals, class disruptions that some teachers feel like they have more tools to manage and other teachers don't, and kids end up getting referred to the office. Peer rejection is a big one that sort of emerges over time, not as much true in the early years, but definitely evolves over the course of elementary school. And parent-child conflict. So just like at school, where teachers are asking kids to do things that are difficult for them, you guys who are parents at home are asking kids many times a day to do things that are difficult for them or are counter to what their brains and bodies are trying to do at that moment of time. And so these are all great areas of intervention, and I should mention that if any of you has a child who doesn't have a diagnosis of ADHD or maybe is one of those kids who doesn't meet the full criteria for ADHD, these are all things that can still be intervened around if these are things that are causing challenges for your family. So this slide I put up here because I think it's important for people to sort of, again, in the service of educating yourselves about what ADHD is, what it looks like, how common is it, what happens over the course of it, it is useful to sort of think about, okay, this is a disorder that tends to stay with people for the most part through their lifespan and can have a pretty big effect. These findings come from a range of studies, and they in no way mean that every child who has ADHD will have these difficulties in adulthood, but having ADHD does predispose kids to having more challenges over the course of their lifespan. And that's a piece of the puzzle that I think is important for families to know about as well. So for example, from some of the studies, we know that there's a higher dropout rate, for example, in kids who have ADHD compared to kids who don't have ADHD. And so in the top left there, you can see lower academic attainment. So although there are plenty of individuals with ADHD who go on to college and do all of that, there are more at risk for having difficulty attaining a high level of education. Similarly, things like increased risk of driving accidents and driving tickets, or increased rates of emergency room visits. These are some of the data that have been coming out in the last number of years that really help us understand, okay, there are some real risk factors associated with ADHD, which it makes it fabulous that families like you are looking for guidance and are saying, okay, while we have children who are still living at home, there are some things we want to put into place to try to set them up for as much success as possible. So I'm going to move on to the diagnostic process and then be able to pass over to Julia so she can talk about treatment. So some of you may have gone through a diagnostic process before, some of you might still be thinking about it, and I'll share a little bit about what our clinic views as the gold standard and the kind of practice that we use when we're thinking about that question of, is this or isn't this ADHD for a child? So these are the components of what we would recommend as a best practice assessment. There are three main components to this. So the top left, we have clinical interviews, we have standardized rating scales, and we have a psychiatric evaluation of comorbid disorders. So as we're thinking about ADHD and as we're thinking about all those different symptoms that I mentioned before, what we do when a family comes in is we want to do a very good old-fashioned clinical interview. We don't have a blood test, and if we did, we would be out of jobs for the most part, although we would still be able to do treatment, but we don't have a way to just sort of say yes or no, this is ADHD. We spend a lot of time talking and doing interviews and really trying to gather information for a given individual or a given family. And that's that top left corner, the clinical interview. So what we're looking at is, are these symptoms present? How long have they been going on? Where do they show up? What happens when you make a small change? Do they go away or do they persist? How big of a deal are they? What's happening for the child because of the symptoms that they're experiencing? And all of those things we cover in the interview. And as part of that, we integrate information from rating scales. So many of you have probably filled out rating scales before. So rating scales provide a way for us to gauge in a fairly standardized way. And we like to use rating scales that have scores, so we can compare how one parent of an 8-year-old rates compared to how lots of parents of 8-year-olds rated the same behaviors, to try to understand how typical are the behaviors that this child is experiencing, or how different are they from other kids their age. So we integrate information from parents and from teachers, and sometimes from more than one teacher, or sometimes from babysitters, or sometimes from after-school providers, to really try to round out as much as we can what do this child's behaviors look like with regard to the ADHD symptoms. As those of you who might have a child with ADHD know, their behavior tends to be inconsistent, and so it's highly dependent on the environment. We can't necessarily have a one-on-one interview with a child or watch them in a room for 10 or 15 minutes and be able to say, yes, that's it. Because what we really want to understand is, how do they function in different environments, and how do they function over time, and what kinds of things seem to help, and when are the symptoms more present, and when are they improved. As part of this evaluation, and a bunch of slides ago I had those criteria up, and the last one is there a better explanation for the ADHD symptoms? And that's where the psychiatric comorbidity question comes in. We really have to evaluate, is there another reason why the child is so inattentive? Or is there a better explanation for why they're so fidgety and sort of seem to be jumping out of their skin all the time? And so as part of the interviewing, we're doing an interview to try to understand, what are things like at home, what are things like at school, what are things like at soccer, what are things like at tutoring, what are things like in all these different settings. And then we also want to understand, how is the child's mood? When do they experience worries? How do they handle it if they experience worries? What are some other relevant things that might be going on for them? In the bottom corner here, you can see that if indicated, we'll do psychoeducational testing. We might sometimes need to get an observation in a classroom, but we don't require that information for the diagnosis because it doesn't necessarily specifically point to or from ADHD, but it can be a useful component if a child is having particular learning difficulties. You may have read about or seen different other kinds of tests, or if you call different clinics, you might hear about testing for ADHD, and these are some of the things that people wonder about when they hear about tests for ADHD. So brain scans or genetic tests, neuropsychological tests, which can sometimes be part of psychoeducational testing. And these different kinds of tests can sometimes contribute to our understanding of a child, but they can't reliably diagnose ADHD alone. And so I think that's an important take-home point, that lots of work is going into trying to understand, are there other tests that we can use to augment or support or help our ADHD diagnostic process? But none of these would be considered a substitute for really going through that good old-fashioned interview and trying to understand the child in all their different contexts. So I'm going to circle back just real quick to the assessment of other psychiatric conditions. So sometimes when we're looking at that part of the diagnostic process, we're trying to understand Is this child's inattention better caused by depression? So better explained by depression. So for example, if the child is a teenager is in a pretty significant depressive episode and they no longer seem to care about going to school, they're not paying attention in class, etc., we might say, okay, let's wait and see. It seems like depression is a better explanation. But many times, and in fact, more often than not, people who have ADHD have another condition as well. So it's not that that other condition is a better explanation for it, but it's something we call a comorbid or a co-occurring condition. And what you can see here is that about half the time, people who have ADHD or children who have ADHD also have what we call a disruptive behavior disorder. So those are things like oppositional defiant disorder or conduct disorder. That's true in about 50% of the kids who have ADHD. Anxiety is also fairly common, so about a quarter of the kids who have ADHD also meet the criteria for anxiety. 20 to 30% have learning difficulties, as well as less commonly depression. These rates definitely change when you go into adulthood. We see a lot more depression and anxiety in adults who have ADHD. Also, autism is not up here, but autism is something that we're learning quite a bit about, and autism and ADHD do co-occur as well. So there's a lot of reasons why a key piece of that diagnostic process is trying to understand what else might be going on for a child. And I'm going to pass the mic to Julia.
All the technology straight.
Yeah.
Okay, can you hear me? Excellent. Okay, so I get the fun part because I get to talk to you guys about what to do about these things. So to start, let's see. Okay, a quiz. Which of the following treatments might be effective for ADHD? So we have neurofeedback, cognitive behavioral therapy, or CBT, individual psychotherapy, which we're kind of thinking about as sort of everything else, not including CBT, chiropractic treatments, school interventions, computer-based training, play therapy, omega-3s, parent behavior management training, mindfulness meditation, medication management. So here are the answers. The ones that are highlighted in red do not currently have a strong evidence base to support them for treating childhood ADHD. The ones in yellow have some emerging evidence to support treatment for ADHD, and the ones with green are the ones that we have the strongest evidence base for. And so the ones in green are the ones I'm going to focus on today, with a particular focus on parent behavior management training. So why is this important to know as parents and also as providers and people in the school system is as you think about kind of next steps, right, of what to do, where to put your time, your resources, we have a big push of wanting you to do the things that have the most support. So we think it's important for folks to know. That said, it's also important to think about that these are based on studies that have large N's or large sample sizes, and obviously kids are going to have individual responses to each of these types of treatments. So one of the places that we gather this information from are our randomized control trials. One of the largest ones looking at ADHD treatment is the MTA study, or the Multimodal Treatment of ADHD Study, MTA. And this was a very large study of almost 600 kids enrolled. And it was a multi-site study, of which Duke was one of the sites. And what the goal of the study was to figure out what are the best treatments for ADHD. And so they had 4 groups. One of the groups was medication alone. One of the groups was behavioral treatment alone. One of them was a combination of those two, medication and behavioral treatment. And one was a control group where they told parents to do what they were already doing. And the results showed that the combination treatment, so that behavioral plus medicine, as well as the medication alone, had superior results to the other 2 conditions. This is important to think about as you kind of make choices in terms of next steps with treatment. 2 things going on here. So I'm going to talk very, very briefly about medication for a large part because this is not what Naomi and I specialize in. We are clinical psychologists, so we are the folks doing behavior and psychosocial treatments. But just so everyone is aware, as you probably are aware, is that medication is very effective for reducing symptoms of ADHD. In fact, about 75% of kids show a positive response to medication treatment. In the American Academy of Pediatrics, this is really their frontline treatment for kids ages 6 and above. So what we often encourage parents to do is really talk with their pediatrician or child psychiatrist about options. We want you to have all the information that's out there. Certainly there are things that come along with medication, some negative sides of things. Well, they can be very effective. Like I said, about 75% of kids respond positively, but that leaves about 5 to 25% of kids who don't have a response to treatment. There's often side effects, so not wanting to eat or sleep issues, so we definitely want to think about those. Medicine also tends to, the effect of medicine can change over time, so some medicines, once you've got the dosage right, sometimes loses its effectiveness over time, especially as kids grow and age. Naomi mentioned comorbidities. Medication for ADHD isn't necessarily going to affect comorbidities, so those co-occurring conditions like depression or anxiety. I did include a resource down here for that. Naomi mentioned CHAD earlier. This is a very long website, but if you go to the CHAD website and go to the click on for parents and caregivers, there's a really nice kind of chart that describes medication. It can be really helpful for sort of understanding what the latest information is on medicine. So tonight, what we really wanted to focus on are some key principles that are sort of underlie some of these behavioral treatments. And we're going to focus on parent management training, one, because it has a good evidence base, and two, because the principles that are sort of part of parent management training can also apply to a lot of the other psychosocial treatments that we think of. So we're going to kind of dive in here. Also, it was nice to see that there's lots of parents in the crowd, so this will apply mostly to you. But we will also kind of take a step back and think about some other treatments, and these principles will be the same. So parent management training, just to kind of also tell you a little bit more about it, it's not necessarily a discrete treatment in and of itself, but it's really more of an approach to treatment that's based in social learning theory, and it targets kind of dysfunctional parenting practices that might be maintaining some of these behavioral difficulties that we see with kids who have ADHD. So the first thing I want to remind you of is your A's, B's, and C's. So this is the model that we think of a lot in parent management training, but also as well as other psychosocial treatments. So when I say A's, what I mean is antecedents. Antecedents are anything that happens before a behavior occurs. So sometimes I talk to parents and have them think about kind of the who, what, when, where, why, what was going on before you asked your child to do whatever. What can you anticipate happening based on your previous experience of being this child's parent? And how do you set the stage for certain behaviors to occur? How do we set the stage so that kids are more likely to meet the expectation that you're setting? The behavior is what your kid does. And the consequence, or that C, is whatever happens after a behavior. So this can be positive, it can be negative. It really is just whatever happens next. And what we want to think about with these C's or these consequences is what is it that we as parents are doing to potentially maintain a certain behavior. So for example, an antecedent, perhaps you are coming home late from a talk on a Tuesday night. Your child has had a long day. They've been at school all day. They're tired. They're sitting on the couch. The TV's on, and you need them to get ready for bed. How do you get them to do it? How do you set the stage so that they're going to follow all the steps? They're going to turn the TV off. They're going to go put on their pajamas. They're going to brush their teeth. That can be really hard sometimes, right? So how do you make that more likely to occur? And then after they do whatever they do, if they turn off the TV and run up the stairs, or if they sit there and ignore you, or they don't seem to listen, or whatever the case may be, what do you do next to make that behavior either happen more often or less often? So I want to talk a little bit more about some principles that, again, kind of underlie this sort of program and really target kind of the difficulties that we see with kids with ADHD. The first principle that we think about is immediacy. And so what we want to try to do is provide immediate feedback about behavior. Why do we want to do this for kids with ADHD? Is because they have a particular difficulty connecting behaviors and consequences. And this gets back to that slide that Naomi was talking about the way that brain trajectories. This is a really challenging thing for kids with ADHD to do. And so what we want to try to do is provide them with as much immediate feedback to the point of their behavior so that they're better able to pair behavior and consequence. So some examples of this, earning a token in the car for keeping their seatbelt on the whole way to school. Why a token? So this might be something that you easily have accessible in the car and you can give it immediately while they're still sitting in the car, right? Rather than later on in the day being like, hey, remember that ride to school? You did really well then. By that time, they're gonna have a really hard time remembering that occurred and pairing the behavior and the consequence. Implementing a timeout for non-compliance while shopping at Target. It's like every parent's worst nightmare, right? And but this is also giving immediate feedback about a behavior, right? When we're teaching them how that non-compliance while shopping can be, we wanna give them feedback that that's not the behavior that you wanna see. Patting a child's knee during a movie to indicate that they're doing a good job for not calling out. Again, rather than waiting till the end of the movie or waiting till later on, we want to try to give that immediate feedback. The second principle that we think about is frequency. And with this, again, same kind of thought of we want to give as much frequent feedback about behavior that we can. Kids with ADHD, as we mentioned earlier, really kind of lack that self-awareness. Well, some kids who don't have ADHD can start to kind of internalize and do some of that self-talk. Kids with ADHD are highly, highly influenced by the environment. And so we want to try to give them as much frequent feedback as we can about their behavior to really help them regulate themselves. So some examples of this are giving high fives every few minutes during dinner when they're able to stay seated, telling a child at the end of every car ride how they did with using their inside voice, or earning tokens each time a child comes to breakfast dressed by 7:15. So again, the more frequent feedback we can give about that behavior, the faster they'll be able to pair that behavior and consequence, and the faster they'll be able to meet your expectation more consistently. The next one we think about is specificity. With this, we want to try to be as specific as we can, both about expectations and consequences. So again, both about antecedents and consequences. Why is this important for kids with ADHD? Well, we know that attention impacts understanding of parents' instructions. So the more specific that you can be with what you're really looking for, the more likely they're going to be able to really meet that expectation. So for example, if you say, I need you to be good at the restaurant. They might not know what that means, right? And my good versus your good might be different. And so you can see this is the second example. At the restaurant, I want you to stay seated and use your inside voice. Those are very specific expectations that you're setting the stage to be more likely for them to do. Other examples, a checklist for a morning routine where you can really be specific rather than just saying, I need you to get ready for school. It's really, I need you to do these 4 things. Or I really liked how you started cleaning up right after I asked you to. So this is an example of a consequence, right? You giving a specific feedback about their behavior, that you liked that they did. The next one is consistency. And this one, one of the kind of the descriptors of kids with ADHD is the fact that they are consistently inconsistent. And this was coined by Dr. Russell Barkley, who is one of kind of the preeminent researchers in the field. And this consistent inconsistency piece is really what we as clinicians hear from parents is the most frustrating thing, right? Because ADHD is not a disorder of ability. It's not a disorder of intelligence, but it is a disorder of performance and being able to perform certain tasks consistently over time. So you know your kid is capable of doing these things, but being able to do them on a consistent basis is what really can be quite frustrating. And so, what we as parents and caregivers and teachers working with them is we try to be as consistent as we possibly can be in the feedback that we give them or the expectations that we set so that they are able to be more consistent themselves. So some examples of this, so earning a small reward every time a child turns off the iPad the first time they're asked. Posting the family behavior rules on the fridge. So this allows you to kind of really set the stage for what's acceptable behavior in your home. And implementing a punishment every time a child hits a sibling. The next one we think about is meaningful. This one we're really thinking about how do we make both kind of rewards and consequences meaningful for kids. What we find a lot when we're working with kids with ADHD is that parents say they just don't seem to care sometimes about the consequences or the rewards. One day they do, and then the next day they don't. And that makes sense, given what we know about the brain development of kids with ADHD. They really need more novelty. And so because they lose interest quickly, we want to try to keep things as novel so that consequences and rewards are meaningful. One of the ways we think of doing this sometimes is creating a rewards menu, so they have some choices in the rewards that they can earn. And we have small things on there, medium-sized things, bigger things that they can kind of work up to. Also asking your child what they want to earn. This can be a really easy way to find some interesting things that kids want to earn that you wouldn't have thought of, but they're meaningful for them, and so that can be incorporated into their rewards menu. This next one is differential attention. And it's essentially what we're thinking about here is how do you use your attention to change behavior? So sometimes I encourage parents to think of their attention like a spotlight. What you shine your spotlight on is what is going to happen more often, and what you purposely remove your spotlight from is going to happen less often. And so what we find is that kids with ADHD, given their behaviors, they often get a lot of attention, a lot of negative attention for the types of things that they're doing. So there's a lot of redirection, there's reprimanding, there's reminders, just by nature of the behaviors that they're exhibiting. And ultimately what that means is that you're shining your spotlight on a lot of things that don't feel so good, that you actually don't really want them to keep doing. Now some of this is warranted. You need to remind them to do things, right? And you need to kind of help them navigate the world in that way. But what we want to be aware of are the times when you're unintentionally rewarding things or attending to things that perhaps you don't mean to be. And so one of the things I ask parents to do is think about, what would you rather see? So it's often really easy to think of the things we want to change, right? Oh, I just really want him to stop running away from me at the grocery store and pulling things off the shelves. Like, that makes sense. What do you want to see? Parents will say, well, I want him to stop doing that. Well, how would you replace that behavior? What would be the positive opposite? That's sometimes the technical term of what we call it. And so what might be a positive opposite? Maybe it's staying right next to me at the grocery store, and it's using your walking feet. And that's a specific antecedent that you can set when going into the grocery store. You can remind your child of doing that. And you can pay attention to that. A second example, I really love how you brought your plate to the sink with only one reminder. So being able to shine your spotlight on something that you've asked them to do. One thing I didn't mention is that when we talk to parents about this, they say they're just so relieved, right, that something may have worked. Like, they're so relieved they got to the grocery store and there wasn't a meltdown, or whatever it might be. Or there's kind of this idea of, well, they should be doing this anyway, right? They should be doing this. Why am I going to pay attention to something that they should be doing? But again, what we want to do is really make sure that we are paying attention to and attending to the things that we want to increase, and really want them to know that we like those behaviors. We want them to keep going. This last thing on here is ignoring, planned ignoring. So again, removing your spotlight from something is going to make it go down. Now, you can't remove your spotlight from everything. There are things that you have to pay attention to, big things, safety things, things like that. But for minor things like whining or eye rolling or kind of those sort of more annoying behaviors, removing your attention from that can make them go down. The next one is balanced, and this is the last one that I'll talk about. And what I'm talking about here, again, kind of coming back to the fact that kids with ADHD often end up having a lot more negative attention than positive attention. So things are really kind of unbalanced for them in that way. What we want to do is shift that to getting more positive attention to negative attention. The concept here is really time in, really balances time out. But if things are too unbalanced, you're going to have a really hard time changing behavior. And so we talk about, down here you'll see we have aim for a 3-to-1 ratio. We know that if we can give kids more positive experiences, get kind of a 3 positives to 1 negative, there's much more likelihood of changing behavior. So some other examples of this are catching your child being good. So again, shining your spotlight on the things that you really like to see. Or setting up a special time with kids to create a kind of a regular positive experience for them. So looking for opportunities to really give those positive experiences to kids. So core components of parent management training, because those are the principles, right? We apply those principles and that ABC model to some specific techniques that we work on with parents. So these include psychoeducation, so that means kind of giving you more information about ADHD, just like you're gathering here tonight. Effective instructions, that again, thinking about how do you effectively set the antecedents and set the stage so that your kids are more likely to do what you've asked them to do. Establishing behavior rules, again, another antecedent. Praise, attending, and rewards, that's more of a consequence. Again, kind of being able to pay attention to the things that you like and reward the things that you like and want to keep going. Ignoring differential attention is another consequence. Token economy systems, so this might be something people have heard of. Essentially, it's like it is a behavior chart, so it's being very specific about the behaviors that you want to track and reward. And also non-physical and effective punishments, so in particular, time out for younger kids. I mentioned earlier Russell Barkley. This is one of his books that we often recommend to families that outline this, these core components. Certainly, these are things that you can also get with working with a provider as well. I also have two websites down here. That one, the top one here, Positive Parenting Program, PPP. Neither of these are specific for ADHD, but they have, again, those core principles included. And PPP actually, that has it's free for North Carolina residents. So if you log in here, you can get some free resources from them. It's great. And The Incredible Years is another one. So some just take-home messages for parents. Being a parent of a kid with ADHD really requires super parenting. For those of you who might have multiple kids and not all of them have ADHD, you might find, well, wait a second, my parenting skills with this one kid seem to work just fine, but kids with ADHD do require kind of these kind of extra strategies. Parent education is key, which is another reason we're so thrilled that you guys are all here tonight. Understanding what ADHD is and how it affects child behavior and how it affects kids throughout the lifespan is hugely important for being able to advocate for your kid and understand your child and understanding their needs and what you need to do. And also this last one of maintaining a disability perspective. And what we mean here, this is twofold. One is understanding that these things are more difficult for kids with ADHD and kind of having an understanding of that and adjusting expectations accordingly. And also thinking about taking kind of we take a chronic medical condition approach or viewpoint here with ADHD. As Naomi showed that slide, these are often symptoms that extend throughout the lifespan. And so how do you sort of plan ahead as parents for what is your parenting strategies, what are the treatments you're going to employ at certain points, how do you monitor these symptoms? Importantly, I do want to mention sort of the research basis for parent management training. There are multiple reviews as well as meta-analyses, which means they kind of clump together lots of results from multiple studies. And there's some definite encouraging findings. They find most particular increased compliance. So if you have a child who exhibits a lot of non-compliance, parent management training can be extremely effective for that. We also find some evidence for reduced ADHD symptoms, though it is a little bit inconsistent, and what we find is less on the inattentive side. And also improvement in parenting and parent-child relationships. So parents report much more parenting satisfaction after going through this type of program. There are certainly limitations, thinking about kind of short versus long-term benefits, generalization. Again, this is parent management training. There's often a school component, but obviously there's times when you are not with your kids. So thinking about how do you keep these types of these systems going across settings. Logistics of, if you are going to work with a provider, who do you go to? Insurance, where does the kid go while you are going to parent management training? They often are not involved. And certainly parental and child factors. And one in particular I do want to highlight is, given what Naomi mentioned earlier, is that Parental ADHD. We know that parental ADHD, either a diagnosis or symptoms, makes it really hard. It's hard enough to do these skills, right? If you already have your own ADHD symptoms, it makes it extra hard. And so sometimes what we talk about with families is how do you structure, what makes sense to do first? Sometimes it's having parents kind of, get their own treatment sometimes before they're able to move on and do these types of treatments. So I have a little bit more time to talk about some additional treatments. And what, I will talk a little bit more about these, but I think, again, the take-home messages here are that the principles that I've talked about so far, particularly, those antecedents, behaviors, and consequences, they extend to all these other treatments as well. So for parent management training, what I just finished talking about, we particularly think about that for younger kids, so kind of more elementary school age and below. There are elements to parent management training that will extend into middle and high school as well. We find that treatments work best when other family members are involved, not just the kids. That said, as kids get older, they are often able to participate more in treatment and to learn some of these skills on their own. So one of the things that, another treatment that we think about are organizational skills training for children with ADHD. This is where we talk with kids about kind of thinking about their difficulties with attention and time management as sort of as glitches. So really kind of externalizing a bit some of the difficulties rather than internalizing them. It can be helpful to talk about them in a more kind of objective way. And then thinking and kind of really helping to develop some of these behavioral skills, such as materials organization, which certainly escalates in terms of demands as you go through school, tracking assignments, planning and problem solving, and time management. And really with kids, we try to kind of over-practice or over-learn these skills, and so they're able to kind of do these consistently. Again, we very much involve parents in these programs. So for example, we often work with middle school students, and while the bulk of the sessions might be going over some of these things with middle school students, we need parents to be involved to, again, set the stage, set those antecedents up, and then be able to reinforce or reward kids when they're actually trying to use these skills. This next one, I just want to highlight how challenging some skills or some expectations that we have for kids can be with a child with ADHD. And this is the kinds of things that we cover when we're talking in those of the kind of the organizational skills training program. So steps for success with homework. So oftentimes parents come in and say, well, they won't do their homework. Oh, or they won't finish their homework, or they won't turn it in. We have to try to figure out, there's a lot of parts to doing a homework. So for example, these are all the things you have to do to successfully turn in your homework. You have to have the child write down the assignment. They have to understand what they have to do. They have to check the materials that they need and then bring them home. They have to get home with all those materials. They have to do their homework, complete their homework, put it back in their notebook, get it back to school, keep track of it until they get to the right class, and then they have to turn it in. So doing homework is actually a lot of steps, and it's these hit on a lot of areas that are particularly challenging for kids with ADHD. And so what we try to do, again, is set the antecedents up so that they're better able to meet these expectations. So we break these things down of, okay, what are the parts that are most difficult? How do we monitor those and help you meet that expectation? And then once you've done that or attempted to do it, because a part of this is also just putting in effort in areas that maybe are more challenging, how do we reward you? How do we reinforce you and make this meaningful for you? Other things that we talk about are homework plans and rules. So homework, sometimes we think about setting aside protected time to do homework, making sure homework is mandatory, thinking about what are the factors that are needed to get these things done. You probably need a start time, a special place to do the homework, making sure that you're limiting distractions. Who's going to be responsible for limiting those distractions? Is a parent going to hold the iPad or the phone? Thinking about how long are you going to work for? Are you going to set a timer? How long would that timer be? and thinking about how long is that break going to be. Make sure that you're setting timers for breaks as well so they don't turn into much longer than you intend. And thinking about also how do you plan your time so that you're getting things accomplished both that are due tomorrow, but then also studying so that you're prepared for things that are coming along down the pike. Again, these are really challenging things for kids with ADHD, and so we want to try to break this down and make it more explicit. And of course, rewards for trying these new skills. This is another thing that we teach in our organizational skills program. This is our GLAD skill. So we talk about you'll be glad when you have a plan. And this is talking about long-term planning. And this is, the first thing is we have kids do is come up with a goal. What are they trying to do? Are they trying to just turn this assignment in? Are they trying to get a B on the assignment? And listing the steps. What are all the steps that they need to do to accomplish this goal? It's really interesting working with kids with ADHD because their list is often quite short. They usually say, well, I gotta just, do it and turn it in. It's like, okay, well, let's break that down a little bit because as we saw with that homework example, there's a lot of different steps. And so helping them really flesh that out and understand all the steps that go into that. Arranging the steps, figuring out what it has to be done first before you move on, pulling out a calendar and a planner and figuring out when am I going to do these things so this other part is done. If I need my parents to help me, when are they available to help me? They might have other things going on. And then figuring out, really assessing, did it work? Did I meet my goal? And would I do anything differently next time? So this is another kind of piece that we think about with kids. So the last thing that we think about in terms of treatment is school-based interventions. I'm glad there's some folks from the school system here, and I can imagine some of the parents in the audience have probably interfaced with the schools to try to think about school support services. What we know is that kids with ADHD benefit from school staff and teachers who are knowledgeable about ADHD and the associated difficulties. They're flexible in their teaching style, and they really view the problems that are associated with ADHD as separate from the kid themselves. This isn't always the case, but when you can find folks in the school system that kind of meet these criteria, it can be really helpful for navigating the school system. So one of the primary things that we think about, and again, I come back to that principle of A's, B's, and C's. So we want to try to set up the environment at school so that the child is best able to meet those expectations. And then once they do it, how do we give them consequences, both positive and negative, right? One of the most effective tools that we have to do this is something we call a daily report card. And sometimes for older kids like middle school, we think about more like a weekly report card. So I want to go through that in just a moment, but before I get there, I did want to mention some more formal school accommodations like a 504 plan or an individualized education plan. We don't have slides on that tonight, but I just want to make parents aware that these are kind of formal school services that kids with ADHD can be eligible for. The process for doing that usually starts with talking to the school. It does start with talking with the school and actually putting it in writing as a request. Something we can give you more information on if you're interested in, but I also highly recommend talking with your school counselors as well as your child's teacher if it's something you're interested in getting. Oftentimes things that go on a 504 or an IEP are things like that can be helpful for kids with ADHD, like extended time or separate setting for testing, or having somebody take a look at their planner before they come home to make sure that the right assignment got in there. So these are things that sometimes can be incorporated. So as I mentioned, I wanted to just go over a daily report card in the couple minutes that we have before we pause for questions. Essentially, again, coming back to the larger principles, this is another example of an antecedent. And what you're doing here is setting up as being really explicit about the behaviors that you are looking for from a child within the school setting. So we establish clear goals, and we think very carefully about what those goals might be. We also want to think about, and goals might be, for example, raising hand during English class, or only gets up from seat 2 times during the morning class, or whatever it might be. So we think really carefully about what those might be, incorporating particularly where the child is right now in terms, we don't want to set an expectation that's too hard for them. And we set about 3 to 4 goals at a time on their behavior chart, and then we track them. And we use, and the teacher, this takes a lot of, you want to try to work very collaboratively as much as you can with the teacher. The teacher tracks this for them. And at the end of the day, because the daily report card, you get that feedback. So the daily report card kind of serves as both kind of, again, that antecedent for telling the child what it is that you want them to do, but also as a way for parents to implement consequences at home, again, positive or negative. So we often talk with parents about what is an appropriate expectation for the numbers of check marks or smiley faces they might be able to achieve in a day, and how does that translate to a reward or some sort of positive outcome for them. Again, we see a lot of things on here that we talked about earlier, giving frequent feedback, making sure to be as specific as you can about what the goals are on their daily report cards, motivating the behavior with meaningful consequences, and being consistent across the time, over time and across teachers. I mentioned 504s and IEPs just a moment ago. A daily report card can be one of the kind of tools that are put into one of those programs so that it's part of their whole plan. I also down here included a resource that you probably don't want to write down the whole website. It's a little bit tricky, but if you look at if you Google daily report cards, this is something from Florida International University. It has some great resources on there, both for parents and teachers. So we're actually right on time, which is kind of amazing. So we want to just conclude and then we'll take some questions. So as we discussed tonight, ADHD can be present and cause impairment across the lifespan. And we want to think about what does it look like across the lifespan? How is it going to change? How do we effectively intervene across the lifespan? Effective medication and behavioral interventions are available. And as we know, combining both of those things is usually what is found to be most effective. And then considering the need for routine checkups to adjust your child's treatment over time. What your child needs right now isn't what they're going to need forever. And so being able to sort of recognize that and know that things will change. But how do you kind of adjust what we're able to provide them to give them support that they need as they grow? So I think that we'll take questions for a few minutes if you guys have any. And thank you. Sure, yeah. Oh yeah, absolutely. We will repeat the questions. And I forgot to mention, we do have some resources here. And we also have our email addresses. I'm gonna stay on the resources so that people can take them down. We also have some cards up here if you'd like them. I saw a question in the back. Yeah. Sure. I'll repeat the question. So the question was that I had mentioned that having a space to do homework that is free of distractions can be really helpful for kids, but the question is that there is also some competing theories to that of having sounds in the background or music in the background can also be really helpful. So my response to that is that I don't know what, I think that the literature is probably mixed on this. I'm not as familiar with it. I think that, as I mentioned, I think a lot of these, that list of treatments at the beginning, for some kids, some things are going to work, and for some kids, they aren't. I think what we do find most consistently is limiting distractions typically is most effective for kids, and distractions, and so limiting that they're not close to a window, for example, or that the TV's not on, or a sibling's not running through the room, or the cat's not coming in, or whatever it might be. Most typically for kids who have difficulty paying attention or difficulty staying seated, it's going to be better to limit those. Now that said, certainly it will vary from kid to kid.
Yeah, I would just add that keeping in mind one of the big take-home messages is that children with ADHD are highly influenced by their environment. And they're more influenced by their environment than they are by their own internal controls. And so what we want to do is think about for each person, what is the right environment that's going to set them up for success? And I think that's maybe where we see some of that variability. For some kids, music helps. For some kids, music is distracting. Even if you think about, there's a frequent IEP goal that's written is preferential seating. So we used to always say, sit close to the teacher. Well, for some kids, sitting right next to the teacher might not be the best place to sit because maybe it's right next to the door, and then the hallway is distracting, or whatever it might be. So I think the guiding principle of what's the environment that might work for this child, and testing it out. So we talked about those ABCs. The other way to think about that is that you guys become the keen observers of your child's behavior. You start to really pay attention to those antecedents, and we see, okay, can we tweak them this way? Add music, add a different kind of music, take away music, whatever it is. And then let's pay real close attention to the consequences and tweak those. And it might take a little time, just like with medicine. If you've had that experience with medicine, we have to tweak it a little bit. We have to try different things. We try different times that we dose it. And so the piece about the super parenting is so true, and I imagine that might ring true for some of you, is that it's not that any one of these solutions will be the answer, but you guys arming yourselves to say, okay, I'm going to have to be extra keen about where we do homework, or when we do homework, or when we dose medicine, because my child is a little bit more sensitive to these variations. Yeah. Any other questions? Yeah. Mm-hmm. Sure. Yeah, so the question is that it may vary depending on the individual, but are there things like lifestyle modifications, exercise, caffeine, things like that that can help an individual? Yeah, I mean, I think, as Julia mentioned, so we were presenting, and what we tend to practice and recommend are the evidence-based practices, the things where we have the most data or the most studies to support them. And the field continues to evolve. So something like exercise in particular, a lot of people are looking at that, regardless of ADHD status. And so I know some schools are using this Go Noodle, I think that's what it's called, where you can, kids can get up and dance and do wiggle breaks and things like that. That probably helps everyone. It helps me, right, to get up and go, walk around, visit a colleague, or go get a drink of water or something like that. So for my thought on all of those things is that many times there are extra things we might do, and probably supplements might fit into that, like omega-3s was one of the things that was highlighted in yellow, exercise, different things like that, that come at a pretty low cost, are pretty easy to do, don't take a lot of family time and resource, and if they work for a given individual, I think they're great to pursue. We just can't necessarily say there's this big wealth of data that suggests, yes, you should do that, if that makes sense. Anything else? Yeah. Sure. That's okay. We'll try. Yeah. Mm-hmm. Mm-hmm. Yeah, so the question is about, from a teacher perspective, the question of about time off of medicine. So not giving medicine on the weekends or over vacations. So just as a reminder that we're not medication prescribers, but we do talk to lots of families about medicine. And so medicine, just baseline, is a very individual family decision. And I think a conversation with doctors about whether that's okay is sort of the first step. A lot of doctors do say that that's fine to do, and I think in particular when there's a lot of side effects. So if there's weight issues and insomnia, it can be helpful to give kids breaks so that they have a chance to sort of get the calories and get good sleep and things like that. There are some kids, though, who have difficulty adjusting if they go off and on their medicine. So here I'm thinking more of like weekend on and weekend off. It can be a little bit more difficult for them. I think summer is a slightly different case. Yeah. So I don't think that there's much in the treatment literature, like in the medication literature, that points one way or the other. to guide about that question.
I don't think I have anything to add to that except that, I mean, I think just as a side note, is that as provider, psychologists, parents report that they do this a lot. So I think that, yes, again, they obviously are doing this well, not obviously, but most of the time they're doing this on the advisement from their medication provider. Right. 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 Yeah, yeah. Right, right. Yeah.
Yeah, I mean, I think the other piece of it is that, so the question is, when they go off and on, does that have a negative impact? And so again, just like we're trying to observe behavior and figure out what helps, for some kids, it's the school demands, that school setting, that makes it so difficult for them to function, and the medicine helps make it easier. It doesn't make ADHD disappear. It makes it, just like when I wear my glasses, I can see you guys all perfectly clear. I could see you without them. I'd be squinting a little bit. I'd be trying just a little bit harder, right? So for some families, the way the routine works at home, it works okay without medicine on the weekend, and that's a choice that they make. Yeah. The other piece that might play into that is that we do want, as kids get older, we want them to be more involved in their care and make decisions about their care. And we want them to understand all the components of their care. And so sometimes negotiating about medicine becomes a piece of that as well. Yeah. Yeah. So the question's about when to involve kids in discussions about medicine. And I think it's, I don't know, do you mean whether or not to take medicine, or just sort of all of the above? Yeah. So so it varies quite a bit how much insight kids have into their behavior. One of the ways we think about this often is when families are wondering about even starting medicine in the first place. If kids are perceiving that they're getting into trouble a lot, they're feeling badly about themselves, getting a lot of negative feedback, I think sometimes that's a time where talking about medicine can be really helpful, because it can help acknowledge for the child, this is kind of beyond your control. This is a way that your brain is built. These are the things that are hard for you. Medicine is something that can help. And then I think as kids get older and have more questions about it, the conversation can be a little bit more nuanced about learning to notice, what does medicine do for me? How do I feel when I'm on my medicine? How do I feel when I'm off my medicine? Sometimes older kids will make comments about they feel like they're not themselves, or they feel, and then that is really important to take back to the doctor to say, is there something different we could be doing? Yeah.
Only that, just to highlight that, I think it's a really important skill for kids as they get older to be able to reflect on how the medicine affects them. We work with a lot of kids who are about to embark and go to college or move on to something else, and they're really the ones who are going to be making the choices, and so encouraging them to sort of reflect on it, like how does this help you? What do you notice? Because yeah, that's a process they don't always engage in naturally. So, yeah. Sure. Yeah. 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 Right. Yeah. Yeah. Right. Yeah, he's exhausted, and yeah. So just to repeat the question, because it's a hard one to answer. But I mean, the question is, for a kid who's highly motivated, right? You don't necessarily you've already implemented a lot of these skills, but he's not necessarily a kid who needs that environmental structure in the same way. But he gets to the end of the day, and he's just he's done. He's exhausted, and he's emotional and anxious. And how do you handle that? Oh, I mean, it's one. I could just validate that sounds really hard for both you and for him. And you know what I might consider there is if there, and it sounds like he has been potentially in treatment before. And if there's anything in treatment or anything that you use as an educator for helping with emotion regulation skills, whether it be deep breathing or watching a certain video or any of the types of skills that we work on with in kids that age, and almost like using a behavior chart around that. Like, what if one of the things on his token economy, if you had one, was like, when I start to get overwhelmed, I deep breathe, right? And it kind of reinforcing that skill, because that's something we want to build into his repertoire, right? We want him, he's going to feel overwhelmed. How can we help build that skill to kind of manage that piece? That might be my first step. Any thoughts? Yeah? Okay.
Yeah, no, I think just to echo and build on that a little bit, many times for kids, you guys may have this experience, they do get overwhelmed, but they don't notice it until all of a sudden they're screaming at you, or things are balled up or in the trash, or they've like ripped the paper from erasing and things like that. So the breaking down piece of it is not breaking down the assignment, but is breaking down how can I tell how I'm feeling, and when am I starting to feel a little bit revved up, and what can I do about it then? Because it's a whole lot easier to calm down at the beginning than at the end. Yeah. We are getting a signal for one more question. Yeah. Yeah, so the question is, any correlation between head trauma and ADHD? And I think there are, attention symptoms, memory problems, difficulty with the executive function certainly can result from head trauma, I think probably depending on the trauma. I guess whether or not that's the same as ADHD that's maybe sort of wired from birth, I guess I don't really know. I think people do talk about maybe an acquired ADHD. Diagnostically, one would have to figure out what to call that, but I think if the symptoms are the same and the challenges are the same, and maybe we understand this happened after a trauma, we would still want to treat the symptoms. I don't know medicine-wise. I think that would be something for a doctor, though. Yeah. Thank you very much. Am I passing the microphone back to you? Okay. We can hang around for a little bit if there's extra questions.
Awesome. Thank you so much. Super helpful. Thank you for sticking around for questions. I also noticed you have your cards and a little bit of information over here. We've got information about Hill outside. I'm happy to also stick around if you have any questions about Hill. Thank you so much for coming out. This is our last event of the year, but I hope you can sign up for our mailing list on our website. Keep apprised. We'll be announcing our professional development calendar in May and rolling out our community education series for next year, and hope to see you all back here sometime. So thank you.